Thank you so much. So we're a double act here today. So my name is Fiona. I'm here today to present alongside Chris for Northwest London PSRC.
And good afternoon, Symposium. I'm Chris Pavlakis, one of the Public Contributors Advisory Group, working with Fiona for more than 2 years on this project.
Thank you so much. So we're here also representing a much larger research team, so it's a really collaborative effort as well with designers, researchers, behavioural scientists, also our healthcare colleagues working in the NHS, and also obviously our public steering group who've been with us along the journey for the last 2 years. So a little bit about the project and how it came about. So when our colleagues at Imperial NHS Trust were looking at their outpatient attendance data, so when they disaggregated it based on ethnicity and deprivation, they found statistics that I'm sure you're also seeing commonly in your own healthcare attendance data. So they found that when they looked at patient groups, they found that certain groups are more likely to miss their first outpatient appointment in a care pathway. And those were patients who were living in the most deprived postcodes of Northwest London, and also patients who were from minority and ethnic groups. And obviously, as we know, when it comes to outpatient appointments, and especially the first one, that's a really important access route to receive specialist care, diagnostics, and treatment. And then ultimately, as if this is our first kind of interaction with the healthcare system, that's going to then lead to inequities when it comes to poorer healthcare outcomes as a result. So with this project, we really wanted to focus on that inequity between different patient experience, access and outcomes. And we wanted to understand what are these barriers that patients from these groups are experiencing, and then how could we co-design and then test some solutions in a clinical trial to combat these barriers.
So the problem starts before the individual interacts with the system, before checking in with the hospital. And to take one of the questions asked this morning by a guest presenter on perioperative care, is it our problem? It should be from equitability and patient safety perspective, because there are external factors, some of which have to do with the position you have in society, in the community, the way you enter the world, that get in the way of even accessing these services. So with these thoughts, 8 people with lived experience, former patients, carers, members of the community, gathered around this space, this project, to bring perspectives they experience firsthand themselves or the people cared for, and were represented in quite a few bodies that were set up to design, implement, or steer the course of the research, to enrich it with their perspectives, to comment on, to ask questions in meetings, and to accompany this journey.
Thanks, Chris. And also just to comment as well, I think the group was really good to challenge the research team as well. So for example, the first phase of the work focused on understanding what the barriers were. So we interviewed a wide range of patients who'd missed their outpatient appointment who were from those groups. And actually some of the different barriers came up. The research team looked at them and thought, actually, we want to focus on these ones, but actually the public steering group said, actually, these are the ones that we think would be most valuable to focus on based on our own lived experience. So things like transport was actually really prioritised by that public steering group, and then that fed into the interventions that we developed as a result.
And to the extent that the agenda was set collaboratively, changed along the lines of thinking and the experiences brought in the room, and was in the end owned by everyone.
Mm-hmm. So also a key part of the project, once we'd understood what some of the barriers were, we then brought again those prioritised barriers that we'd selected alongside the public steering group, and we brought them to a series of co-design workshops that we held in local community venues with people from the local community in Northwest London. These 3 workshops built on each other. So you can see in the first one, it was all around brainstorming solutions to actually come up against these barriers that, again, were around transport, issues with communication barriers, things like that. And you can see we brought a how might we statement to each of those workshop groups, and we kind of brainstormed. Again, there's no wrong idea, and it was very creative and collaborative, and also a warm process as well. Then we, at the second workshop, we iterated on those ideas and started to build out, what are some of the practical aspects of this. And actually in this workshop, we had our local community members, but we also asked healthcare staff who were working in those outpatient clinics to join for that workshop, because it was really important that any solutions that we developed also were acceptable to them and also were feasible within the NHS. And then the final workshop was playing back those ideas. So we developed a series of prototypes that we then play back in some storyboards that we shared to the workshop participants. And also some things about what worked well. So again, like I said, around booking local community venues that people were familiar with, local caterers also to provide food to the events. Also, of course, paying people for their time and also making sure that, again, creating a warm environment in the workshops, which again, Chris and the public steering group were really invaluable for.
And access needs are recognized and accommodated in a way that enable that meaningful participation. It is very important to say that the third phase of this process, the playback, was quite enlightening in refining the ideas and coming up with some clarifications or increasing the depth of them. And the venue, the choice of the venues where these workshops took place mattered, in the sense that they were close to the community, close to the people living from an accessibility point of view, but also not institutional settings, but encouraging this relational over the action, this result-oriented, result-focused, and that worked.
On the next slide here, we have our top 5, then our design concepts or ideas that came as a result of those 3 workshops. And again, these were prioritised alongside with the public steering group, and these were based on the initial barriers that we heard. So one of our ideas, again, was around transport, so actually paying for patients' transport. We heard so much around the issues in terms of getting to hospital appointments, whether it's someone with a freedom pass and they can't go to early morning appointments, which they're always being given, and they have tried to tell someone about it, but nothing happens as a result, or even issues with the patient transport, again, long waiting times, and again, that piece around intersectionality, where people might have caring responsibilities, multiple appointments. Something I think that was probably the most popular idea was around health navigators. So having someone actually embedded within the community that maybe they volunteer or they work with the local NHS services, and particularly around they might speak the preferred language of someone within that local community to build trust, to also understand around overcoming barriers when it comes to maybe what to expect about the appointment, maybe bringing someone to the appointment and helping them to overcome different issues around that. Something around communication preferences, so something that we heard this morning around that patient safety incident, around actually translating or modifying comms where possible. So again, those appointment letters, where it's really standard information that could be maybe translated into maybe the 5 or top 10 most spoken languages within the area. That was really, people were keen to do that. Also around allowing people to RSVP to appointments. So again, it was really kind of one-way and transactional approach, and where that patients were being given these appointment times, they just could never make this appointment that they were going to get given, and they had no way to communicate back to the hospital. Maybe they were working full-time, or they tried to get through to the hospital phone line and just were waiting for so long. But for an easy way to do that, and then also around explaining what to expect at the appointment. So again, and we've heard a little bit about it today, was around that kind of fear and mistrust of maybe healthcare services or formal healthcare settings. And really people want to know what to expect before, during and after, and also to build that relational aspect as well, kind of working with the NHS.
If I may comment on this top 5, the themes that emerged through the workshops, it may happen to all of us to miss an appointment because things get in the way, life stuff. But to some members of the community, fellow human beings, neighbors, even family members, there are barriers that seem to be too high to overcome on themselves, and that becomes an equity issue when these barriers persist, and there is nothing in the system preventing from these becoming a barrier and putting them at risk of their patient safety, especially if they happen to live already in vulnerable situations. So they seem very everyday life issues, but this is also the depth and the power of the insights that they are very everyday life issues that can be addressed effectively if proper resources are allocated.
Amazing. So then the second last slide here is around, we actually brought forward 3 of those ideas to test in the clinical trial. So those 5 amazing ideas, we were quite constrained in the sense that our research funding, we were actually going to evaluate them in a clinical trial. So we actually modified them and we ran 3 different additional text messages that we sent out to patients, and they focused on helping people to plan their journey, also signposting them that they might be able to have their travel costs paid for, and also something around helping people to know what to expect. And again, the public steering group were really helpful around this to actually shape the language and tone of the messaging. We heard again from public members so often that it's very harsh and just not very nice, the text messages and the letters that people get sent, and actually making sure that they're very warm and friendly. And also each text message then linked to a new web page that we created on the Trust website. And again, it was co-designed with our public members and alongside our design team as well to make sure it was really informative, all the information was in one place. And even this example of the what to expect page, we actually got a member of the team to take lovely photographs of the different team members, so they actually might be people that they might actually meet when they come to their first appointment.
In the initial draft agenda, this session was phrased as success stories, and when preparing for this presentation with Fiona, we wondered if this is a success, and we agreed that we were on track and we delivered, and not because we managed to solve the problem, the job is not done, but because we built capacity for anyone involved. If I'm standing here and nothing qualifies me academically or professional, it's because I was empowered by you, Fiona, and the team are working together for 2.5 years. And this is true for everyone involved, that we started something, we took the literature forward by creating these insights. You can see the bullet points with the concrete takeaways, which is a call to action to all of you. If you find something that can be replicated in your own organization, in your own context, please do consider to build on what has been achieved, what was co-produced, and take it forward, because it's, as we argued, patient safety and equitability issue, and this should be given attention.
Yeah, thank you so much, everyone.